So my name is Kush Desai. I'm Assistant Dean for the Medical College of Georgia's Southwest Campus, part of Augusta University and part of the hub team for the Georgia Colorectal Cancer Control Program. I'm also a general internist practicing in rural Georgia. So that we can get to know each other, please indicate your name, the name of your clinic, your role at the clinic, or the role at your institution, and your email address. You can see an example in the chat box. So here's today's agenda. You can do next slide. There we go. So first we start with introductions. We're doing that right now. Then we go into our didactic presentation. This is going to be given by our expert presenter, Dr. Alok Khorana. Our next section is the case presentation given by the clinic Wadley. This is part of the East Georgia Healthcare Center FQHC, and we end with case recommendations. Next slide, please. So the motto for this Project ECHO, or motto for all Project ECHOs, is moving knowledge instead of people. ECHO stands for Extension for Community Healthcare Outcomes. It's the principle, or it's the platform that was developed to spread knowledge throughout the world. The concept is based on having a hub team. The hub team has experts that give knowledge to spoke teams, which are providers from all around the country and all around the world. And those spoke teams, or those clinic providers, also give knowledge back to the hub team and to each other. So it's this concept of bidirectional and multidirectional learning. TeleECHO so just some general reminders. This is being recorded, and we do collect data for the purpose of research and feedback. Next slide, please. It's just saying the same thing, that we do collect data for the purpose of quality improvement and feedback. Just some general Zoom reminders. Remember to mute your microphone when you're not speaking and to unmute yourself when you do speak. We do encourage questions. Remember, we have this concept of bidirectional learning, so we want lots of questions, lots of discussion. So anybody that has any questions, please put your question in the chat box. For those of you guys that have been on these sessions before, you know that sometimes I'll just call out people from the audience to ask specific questions or to get the feedback. So don't be alarmed if I do that. But we're just trying to encourage dialogue. Next slide, please. So I'm happy to introduce our first presenter. This is Dr. Alok Khorana. He's a professor of medicine at the Cleveland Clinic and the director of GI malignancy program at the Cleveland Clinic. His clinical and translational research focuses on predictive factors in drug development in cancer-associated thrombosis and GI cancers, and he's been funded by numerous grants, federal and private grants. So his talk today will be on young onset colorectal cancer, investigating a mysterious rise. Dr. Khorana, you can take it away.
Great, thank you for that introduction, and thank you all for joining us today and for the invitation to present. So I know this group has been very much focused on screening for colorectal cancer, and that's actually been very successful. But I want to describe some new findings that are emerging and that bring into sort of issue whether we need to change our public health approach to colorectal cancer. Next slide, please. So first of all, the good news is on the left, and I think you've probably seen this many times before, which is that as screening recommendations started getting implemented in the 90s through now, the incidence of colorectal cancer started to decline in the United States. And you see that in the sort of the chronological graph on the left, where both the incidence in men and in women started to decline, starting sometimes in the 80s and 90s, and then persisting until now. And it's actually at one of the lowest levels it's been in the past half century. And shortly after that, we also started to see a decline in mortality. So not just that we're impacting the disease incidence, but also when diseases like this are discovered early, we also impact the bad outcomes from it, including mortality. So that's the great news. The challenge here is that if you actually separate out this graph on the left by age, we see two very different directions. What we see is that there's an even steeper decline in people who are older than age 50, but we see an increase in people who are younger than age 50. And so that's shown on the graph on the right. So if you look at people between ages of 0 to 49 years, Starting in the mid-90s through the mid-2010s, we see an increase in both men and women, in both incidence and now, sadly, in mortality as well. And that's been a real change in this disease. We don't fully understand it, but essentially the incidence of what this is known as, which is young onset colorectal cancer or early onset colorectal cancer, defined generally speaking as colorectal cancer occurring in people less than age 50, has increased by 51% during this time frame. And in fact, we expect that it'll continue to rise. We don't see it plateauing off. And the CDC's expectation is that by the end of this current decade, so by 2030, colorectal cancer will be the leading cause of death in people between ages 20 and 49. And that's really not something I ever thought I would actually say. And so this is a really mysterious change in the way this illness occurs. It's almost always been an illness in older people, and for it to suddenly start occurring in younger people and go up in incidence has been very, very striking. Next slide, please. And it's not just in the United States. I know these names of countries on the bottom are kind of hard to read, but in general, we see an increase in young onset colorectal cancer throughout the world, not just in the United States. And we see it more in countries that have adopted sort of what's known as the Western pattern of diet. But this is across the world. This is not just a US only phenomenon. Next slide, please. There's some very sort of typical features of colorectal cancer that are common, and then there's some features that are different between this young onset and later onset colorectal cancer. And that's shown in this sort of graphic here from a very recent paper in Science. Late onset, which we'll start with, is on the right, and that's sort of the typical colorectal cancer patient that we see. It's usually found on screening. So, you guys are doing such a phenomenal job screening for colorectal cancer. Most often it's found in a routine colonoscopy starting at age 50, let's say. So the chance of early stage diagnosis is higher. The chance of metastatic disease is lower. We do see some specific type of genetic mutations like APC and BRAF. The cancer seems to be more likely on the right side of the colon. And that's sort of the classic, later onset colorectal cancer. In contrast, if you switch to sort of the left side of the slide, in young onset colorectal cancer, family history is more likely. Certainly inherited mutations, which are reflected in microsatellite instability, are more likely. But because there isn't a real screening program for younger people, late stage diagnoses are more common, so more likely to see metastatic disease. And sort of bad actors within histology, such as a poor differentiation, is more common. And then also, even kind of strangely, we are seeing predilection for the left side of the colon and the rectum. So much more likely to be rectal than to be colon. And that's also a change from, usually colon cancer predominates in colorectal cancer, but here we are seeing sort of a much greater incidence in the rectal cancer as opposed to colon cancer. However, there are some features that are frequent in both. Those are shown in the middle. So the classic sort of metabolic syndrome that you're very familiar with seems to be a phenomenon that precedes the diagnosis of colorectal cancer, whether in younger people or older people. Some of the dietary factors that are common etiologic factors in later onset colorectal cancer are also etiologic factors in younger onset colorectal cancer. So consuming sugar-sweetened beverages, red meat, processed meat, the Western pattern diet that I talked about, obesity, sort of reduced mobility, so prolonged sedentary behavior seem to be common with both younger and later onset colorectal cancer. Next slide, please. Here's a list of sort of all the diet and lifestyle factors that are associated with the young onset colorectal cancer. These were put together from sort of a list of different types of studies that have been done. They're not all from the same study. This is sort of a systematic review of the different factors. And they're arranged by sort of the greatest relative risk. So which factor is the most likely or has the strongest impact on the incidence of young onset colorectal cancer. And if you read them from sort of the top to the bottom, you see sort of sedentary behavior, sugary beverages. So this is, the classic sort of Coca-Cola, Pepsi, those types of things. High BMI, Western diet, smoking, of course, meat consumption, alcohol consumption are all associated with increased relative risk. Things that seem to protect are on sort of the bottom half of this graph. So fruit consumptions, vitamin C, but that sort of overlaps the one borders. I'm not sure that that's sort of statistically significant. Aspirin use is somewhat protective. Folic acid is slightly protective. Some other vitamins, and then of course vegetables. So, sort of a healthy diet and a healthy lifestyle seem to be more protective, and less exercise and more meat consumption, more sugar consumption seems to be associated with increased risk. Next slide, please. And in fact, the factors that are being investigated right now, we don't have sort of proof for all of this, but the factors that are being investigated are not just diet and lifestyle factors, but it's also all kinds of other things that have changed in life as we know it in the past 30 or 40 years. And that includes sort of reproductive technologies like IVF, for instance, other impact on maternal lifestyle, increased risk of cesarean delivery, reduced sort of breastfeeding, antibiotic exposure in early childhood, which is a relatively new phenomenon. All the lifestyle things we talked about. Chronic health conditions can also predispose, including, type 2 diabetes, inflammatory bowel disease, obesity, and so on. And what's being addressed is not just all of these factors that are, that people are exposed to during the course of their lifetime, known as the exposome, but also what is being investigated is how do these factors actually interact with your body to lead to colorectal cancer. And so, is it an interaction of the environment with genetics, as shown on the bottom left, so germline genetics? Or is it an interaction of the environment with the microbiome, which is this trillions of bacteria in everybody's gut lining? And are those being altered by antibiotic exposure in in early childhood, or some of these metabolic syndromes, sugar consumption, and this alteration in microbiomic, the microbiomic profile of individuals is leading to increased risk. And these are all being heavily investigated right now. Next slide, please. It should also be noted that just like with any other cancer, there remain racial disparities in young onset colorectal cancer as well. These are data that one of my colleagues from the Cleveland Clinic recently published in Cancer Med. Bottom line is that similar to other cancers, people with young onset colorectal cancer are more likely to be Black, more likely to be Hispanic, more likely to present with stage 4 disease. And interestingly enough, Black patients have a worse survival compared to white patients across income subgroups. And even if you look at just private insurance, because one of the thoughts is this related to access? But this may be actually disease biology, because even with Black people with private insurance have worse survival compared to white patients with young onset colorectal cancer. I think a lot more needs to be studied there as well. Next slide, please. Our group has also identified sort of hot and cold spots. So this is some very interesting epidemiologic work that, I don't have the time to sort of get into the details of how it's done, but essentially it goes down to like the county level incidence of colorectal cancer. And then we focused on the younger population. And then we looked at whether the rates were higher or lower than expected for a population of that age, as opposed to sort of a national representative sample. And if you adjust for sort of all, the county's median age, the number of men and women, race, ethnicity, all of those things, obesity rates, we still found a couple hot spots, those are shown in red, and a few cold spots. Hot spots are where the incidence of young onset colorectal cancer is higher than expected. And as you can see, those are mostly in the southeast, and some where we live in Cleveland, sort of, across the Great Lakes areas. The cold spots seem to be more on the West Coast, as you can see, outlined with the big blue circles. And that's true if you look at less than age 50, if you look at less than age 35, or between 35 and 49, we sort of seem to come up with the same areas that are cold and hot spots. So I think much more needs to be investigated there as well. Why is the location of where people are growing up leading to sort of increase or lesser incidence? Next slide, please. And a lot of this, like I said, may depend on microbiomics, and the microbiomics or the microorganism profile can be different in the gut, and it can be different in the tumor. Next slide, please. And in fact, a bunch of human tumors contain a lot of bacterial DNA, and this is an area that a lot of us, including our research group, are focused on. And as you can see here, across different solid tumors, the percentage of DNA that's in human tumors can be actually very high, coming from bacteria rather than from the tumor cells themselves. Next slide, please. And so, as I mentioned, all of these early life exposures and the elements of exposome can affect microbiome and potentially lead to increased inflammation, lead to obesity, lead to diabetes, and all of that may be impacting this phenomenon of early onset colorectal cancer. Next slide, please. We recently studied differences in the microbiome between younger and average onset colorectal cancer. And again, just for the sake of time, I don't want to get into sort of all the details, but you can see just from the pattern here, the red is older patients, the blue is younger patients, and you can see the patterns are very different in terms of the microbiomic profiles, and they kind of split up into two different groups. Next slide, please. Also shown here. And what we're seeing is that there's some bacteria that we're finding more in younger patients than in older patients. Akkermansia, which is listed in the table at the bottom, is probably one of the highest differences we are seeing, but we're also seeing differences in bacillus rates, listeria, and E. coli rates, pseudomonas rates, and so on, suggesting that the microbiome in younger patients who develop colorectal cancer is different than the microbiome of older onset colorectal cancer. Next slide, please. So I've sort of described to you the epidemiology of this illness, and just in terms of clinical applicability and practical applications, what are things that you all need to be aware of? Next slide, please. Number one is that in terms of prevention, obviously screening is extremely important. This is probably a group that knows that better than anybody else. But it's not just screening based on age, because if you base it on age, there's usually an age cutoff of 50. But we also need to recognize that there are some people that are high risk, and these are people that have known hereditary syndromes in their family, or they have a family history of colorectal cancer, or a family history of polyps, or a personal history of inflammatory bowel disease. And I want to point out that there's very little knowledge amongst sort of the lay population. People seem to know the age cutoff of 50, which has now recently been changed to 45, but they don't seem to know that if they have a family history, that actually doesn't apply to them, or if they have a family history of polyps, that doesn't apply to them. And so for those people, usually the recommendation is starting at age 40 or 10 years before the youngest person in the family to develop a colorectal cancer or to have a polyp. And so it's really important to message that out and make sure that people understand that the standard screening rates, which currently are 45, are for average risk patients, and for high risk families, we need to make sure that they understand that they have a different time of starting screening. And then lifestyle modification, of course, is very important. And then symptom recognition is also really crucial in this younger population. Next slide, please. These are the screening recommendations. All the US societies have changed, as you guys know, down to 45. In Asia Pacific and Europe, it still remains at age 50. Again, incidence there is not quite as high as the incidence in the United States. Next slide, please. So this is the diagnostic delay issue, which is also sort of crucial in terms of diagnosing patients. And younger patients tend not to be believed by their physicians or healthcare providers that their symptoms could be related to cancer. In this survey from the Colorectal Cancer Alliance, they found that out of 800 plus patients, nearly 900 patients, the overwhelming majority were diagnosed at a later stage, and 80% of them had 3 symptoms of colorectal cancer prior to diagnosis. But most of them waited for several months before they went to the physician, and 75% saw 2 doctors before they were actually had the correct diagnosis, because most people will say, oh, it's hemorrhoids, or it's irritable bowel, or it's inflammatory bowel, or you need to change your diet. And so they don't do sort of the obvious tests because they don't think that somebody this young could be getting colorectal cancer. And so extremely important that we don't just attribute something to hemorrhoids or a non-malignant cause without doing sort of the full workup, because this is unfortunately increasingly common in the younger population. Next slide, please. Other issues that are unique to younger individuals with colorectal cancer, this is a very different population than the average onset colorectal cancer population, because this population is not done with, having a family. And it's important that only 30% of patients who are referred to a reproductive specialist should be much higher than that. Post-treatment of colorectal cancer, sexual dysfunction and sexual health and intimacy are commonly affected. The quality of life is affected. So that really needs to be addressed. And sometimes that falls on the cancer team. So sometimes it falls on the primary care team as well. Older patients are less likely to be employed, because they're retired, whereas here, most patients are full-time employed before their diagnosis, and many of them lose their jobs or are unable to continue to work because of their treatment. So that needs to be taken into account. And all of these factors, not just that they have cancer, but that cancer at a time when most of their peer group doesn't have cancer. There may have been delays leading to diagnosis. It's affected their ability to have a family, their ability to have intimacy in their personal lives. All of that can lead to mental health issues and depression as well, more common in the younger population. So I think these are issues that are very unique to this population. Next slide, please. So in interest of time, I think important to keep all of these factors in mind. I'll just speak briefly here, but it's important to create sort of an environment where all of these things are discussed with younger patients, and not just, oh, you have colorectal cancer and we'll treat it, but all of these different aspects of having colorectal cancer as a younger person need to be addressed. Next slide, please. So things that we can deploy right now in terms of solutions for young onset colorectal cancer are that education and awareness between both physicians and patients. Genetic testing for all family members with colorectal cancer. The faster we find high-risk families, the better we can serve them by implementing screening early. Screening guidelines, I think, need to change not just in the US, but outside of the US as well. And then there has to be better communication between healthcare providers and during survivorship in terms of the unique needs of the young onset population. Next slide, please. I think at our institution, we've created, because we recognize all of these different aspects, we've created a young onset colorectal cancer center. I recognize that that's not, that can't be done at every institution, but just to give you a sense of how this can be done. Next slide, please. Can you click one more time? Yep. And so, we have a coordinator specifically for young onset patients. Everybody gets genetic counseling and testing. We make sure that they have fertility preservation offered to them. Provide a ton of psychosocial support, lifestyle medicine. Survivorship is an important aspect of the care that we provide these patients. And of course, we are doing heavy research into this area as well. Next slide, please. So just to summarize, and I don't know if you have time for questions, but to summarize, young onset colorectal cancer is rising at alarming rates, not just in the US, but outside of the US as well. We don't fully understand the factors underlying this rise, but certainly the standard factors, obesity, diet, lifestyle are important. And this may be occurring via influence on the gut microbiome. Our group's identified some clinical risk factors, and it's important to know that in the US, Black and Hispanic patients are at greater risk. And we've identified hot and cold spots where it's important to sort of investigate more. Tumor microbiomic analyses have also identified microbial signatures associated with young onset, and these may prove to be points of intervention in the future. Next slide, please. Lots of unanswered questions, tons of unanswered questions. We still don't fully understand all the different elements that are driving this. Which periods of development, is it, in utero? Is it, early childhood? Is it adolescence that's putting the colorectal area at risk for cancer? The role of the obesity, the role of microbiome, the interventions such as screening, diet, lifestyle. Should everybody be, eating yogurt every day because, that's going to, give you a more diverse microbiome? These are things that we really need to investigate more. I think that's my last slide, so I'll stop here. Thank you.
Thank you, Dr. Khorana. That was a fascinating presentation. Really interesting. One thing that I saw in particular was the cancer hotspots, and kind of zoomed in real close, and it looked like Southwest Georgia, where our grant is based in, is one of the hotspots. So it makes sense we're doing the work where we're doing it. Dr. Hotz has his hand raised. Dr. Hotz?
Okay, thank you very much for that very interesting presentation. And it's something that, our group here has had to entertain, this young onset. And I've got a very specific question because, what are the triggers to do that workup? When I was going through my training almost 40 years ago, iron deficiency anemia was considered colon cancer until proven otherwise. And that was before we had active endoscopy. It would seem to me that we have a lot of people say they bleed. And should that be the trip for doing a colonoscopy? Or, a lot of insurance companies demand that we actually capture something in the stool. But, what troubles me is this weight that people have. And what is the real trigger for starting doing the workup? If we wait for iron deficiency, it's a little late. What would you recommend when somebody comes in, they say they've had rectal bleeding once or twice, do we go straight to colonoscopy?
That's essentially it. You're absolutely right. So, we don't want to wait till they get iron deficiency because that means the blood loss has been ongoing for quite a while. And so it's the change in bowel habits, it's the new onset rectal bleeding. And to me, those would be triggers to immediately send for screening, which in this case would be colonoscopy. I think what we're seeing, I showed you that slide with sort of the delay in diagnosis and going to see 3 different doctors. What we're seeing is that a lot of assumptions are made about, IBS or IBD or hemorrhoids, but, many of those also need at least a flex sig, if not a full colonoscopy. So I think the trigger really needs to be sending patients for colonoscopy with any of these sort of worrisome symptoms, particularly rectal bleeding.
Thank you.
Yeah, that's really interesting. As I was visiting clinics today, one of our very astute providers actually brought up a question about the exact question about young patient rectal bleeding. Do we refer? My response was probably yes, because we don't know if it's coming from hemorrhoids, and with the new rising incidence of younger colon cancer, you probably should. Is that kind of your practice as well, Dr. Khorana, or your advice to primary care providers?
Yeah, for sure. I mean, I think that's actually the most common presumption is, it's hemorrhoids. And then sometimes people explain away the iron deficiency and anemia as hemorrhoids. In women, it's more challenging because a lot of these women might be, had recently had childbirth, or maybe they have heavy periods. And so people make a lot of assumptions. Oh, the anemia is from, having a heavy period, or the anemia is from the hemorrhoids you had post-pregnancy, and things don't get investigated. So I would say err on the side of caution. Colonoscopy these days is a very safe procedure. Worst case scenario, if you don't want to, the patient absolutely does not want to do a colonoscopy, you could still at least do a Cologuard test for DNA. Not quite as sensitive, and it doesn't diagnose the other, if there's inflammatory bowel disease like Crohn's or something, obviously that would not be diagnosed with that. So my preference would be colonoscopy.
And so we have a question, and this will be the last question before we start the case presentation, but question in the chat saying, does a young person need a colonoscopy if they're treated for hemorrhoids using fiber powders, et cetera, and the bleeding goes away?
And the bleeding goes away. Yeah, that's a tough question. Probably not. I mean, if the problem's resolved, but it is something I would monitor, and if it recurs or something, then you definitely need to investigate.
Yeah, that's good advice, and a very common clinical scenario that we see all the time. So very good. Next, we have our case presenters. We can do next slide, please. So our case presenters are going to be Amber Smith and Raven Thomas. They're certified medical assistants from the Wadley Clinic. That's one of the clinics in our grant that's been highly successful in getting their patients screened. We know that this getting patients screened is a multidisciplinary effort, and all of the providers and staff have to be participating. And so we felt like our medical assistants were also doing really well at that clinic. And so we were going to get some input from them on reasons for their success. So Amber and Raven, I think Sable is our clinical liaison, who's an RN, and she's been very helpful as well. So she's also there in the room with them, and she'll be helping as well. So you guys can take it away.
All righty, next slide. So this is our Wadley Clinic. It was opened in 2015. It's a one provider clinic, and we started the implementation with the CRC program in February of 2022. Next slide. And this is just our UDS measures for 21 and 22. The rate's not on there, but this is the demographics, I'm sorry. So as you can see, for men and women, it's pretty much 50-50. However, there is a large amount of non-Hispanic Blacks in this community, which is mostly what they serve. Next. Here's the UDS measure. So in 21, they were only at 31%. And when we started February of 2022, so 11 months, they were able to come up 12% to 43%. Next slide. And this is just the thing from where they started to where they are now. So we went up 20% since implementation or our baseline, and then as of right now, or March 31st, I believe, they were up to 51%. And of course, our goal is 60. Next slide. And this is just a flow chart, kind of just showing a steady increase over 2 years, I'm sorry. Next slide. And Amber is going to explain a little bit of the screening process.
Okay. The screening process, the MA checks the CDSS for the colorectal screening. If needed, the patient is asked,
You mean you can't see?
oh, I can't see.
Let me cut the white on, I'm sorry. You can read this one.
Oh, I ain't touched. Okay. If needed, the patient is asked if they've had a colonoscopy and when. If they've had one, then they'll sign a release form, and so we can obtain the records. If not, they'll be introduced to the HemoSure kit. I would tell them it's a preventive screening, and it is better to find things early so that they have a better chance to fix or improve their problem. The MA brings the kit already made up and demonstrates how to collect and return the kit. We try not to allow anyone appropriate that has not been screened out of the building without a HemoSure kit, medical record release, or referral for a colonoscopy. Next slide, please.
This is our barriers. The first one is the level of education and the inability to fully understand the instructions and importance of the screening, and the patient refusal of the preventive measures. Next slide. Reasons for success. We have started encouraging some of the patients to collect while they are in the office. And if they're adamant on colonoscopy refusal, we stress the importance of getting the screening done, and they usually agree to the HemoSure kit. And we also don't have a lot of staff turnover. Next slide.
All right, very good. Thank you, guys. So it sounds like you guys have consistency in your staffing and enthusiasm from everybody to make sure that patients don't leave the building without getting some form of screening or a record release to make sure that if they've already been screened somewhere else, that we get those records. And it seems like that's the reason for y'all's success. Saba, would you agree with that?
Yes, sir. And I think the encouraging them to collect in the office while they're here has helped them a lot.
How often do y'all have patients that are okay doing that? That's, I think I've heard of that as being called poop on demand before,
Yeah.
but not everybody can do that. But how successful have you been? Like, how often do y'all see that?
They said 2 or 3 a month. It's not a big, huge amount, but it is something.
That's still something. I mean, that's still more than 2 or 3 patients that may not have been screened otherwise. So that's really good. The question from Alicia Vecca is, do you have any issues with patients returning their HemoSure kits? And so I guess that would be patients that have already received the HemoSure kits from you guys because you don't let them leave without it. How, like, do y'all feel like it's difficult for them to get them back, or what's the?
I guess some just don't want to return them, don't want to do it, period.
Got you. Very good. So, and so we use patient navigation as well to try to get those patients to get them to return the kits. And so the patient navigators will call the patients multiple times to make sure that that they return, or at least try to encourage them to return them. That's done by a group, Horizons. That's a nonprofit group that works with us to do that. All right, very good. So we're going to do, if anybody has any more questions, please put them in the chat. But in the meantime, we have some poll questions. This is from our didactic. This is some questions from our didactic presentation just to see y'all's input. And so the first question is, how often do you see patients who have colorectal cancer symptoms at age 45 or younger? In other words, how often do you see the patients with these symptoms that we talked about, bleeding and other issues, iron deficiency anemia and maybe some weight loss and these type of symptoms at a younger age? And we still have some answers coming in, but at least seems like it's something that's occasionally seen, not all the time, but at least occasionally is seen. Dr. Khorana, what are some, so of course you're a medical oncologist, so you see them after the fact, but with the patients that you do see it in your practice that have this young onset colon cancer, like what are some of the more common presenting things that we really need to pay attention to?
I think it's first of all, it's making sure about their family histories. Even if patients don't have symptoms, do they have a family history of cancer or a family history of polyps? People dismiss those or the polyp part also. Second is change in bowel habits, I think is a sort of a big trigger. Some people might lean towards constipation, but now suddenly they're going 3 times a day or the other way around. And then frank blood loss. It is, because young onset is so much more common in the rectum as opposed to the colon, you're going to see much more bright red blood rather than sort of the usual, the older, the black tarry stool and so on. I think having any type of frank red blood would be concerning as well.
Thank you. Yeah, that's really, really helpful to our primary care providers. Thank you for that input. All right, so we'll do the next question is, it looks like that's already been answered as well. So how often do you discuss colorectal cancer risk factors with patients who are below the recommended screening age? It looks like there's most everybody says sometimes, some of our providers did say very often or often. If y'all remember, one of the previous presenters from Dr. Whitney Jones from Kentucky spoke about this concept of lead time messaging. And so that whole principle or the whole main idea of that presentation, his message was that if you start early, they start hearing it multiple times. So by the time they get to screening age, they're already heard it multiple times. But also his point was that for patients that have symptoms or signs or family history, we're also able to capture those patients earlier than the screening age. So his messaging was the 45 is the latest that we should talk about screening, but actually we really should be talking about earlier.
And if I can make one other point about this, so
sure, absolutely.
Sometimes you get actually this one patient's really on my mind because sometimes they get pushback from not from the physicians or the providers, but from insurance companies that'll say, oh, you're only 43, and so you don't need you don't qualify for a colonoscopy. And so we want to differentiate between screening colonoscopy and diagnostic colonoscopy. I had this one poor patient that had, this is back when the rates were, or the cutoff age was 50. And this poor guy had symptoms for 6 months before he turned 50 and even went to his physician and asked for a colonoscopy. And insurance denied him. He appealed it and the appeal was denied. And so he went, like the day he turned 50, he went again for a colonoscopy and he did in fact have colorectal cancer, but by then it was metastatic. It's just really tragic because here's a patient advocating for himself. And you still, end up with this tragic result. So very important that when you send it in, it's, if it's based on symptoms, it's no longer screening, it's diagnostic. And then even to insurance companies, remind them that if you're screening somebody at age 42 because they had a family history, that's allowed by, by all the guidelines. That's recommended by all the guidelines. So.
Yeah, thank you. That's really, really important. So we have a lot of patients, of course, that, I think you saw some of our demographic factors for one of the clinics, but a lot of patients that are uninsured. And so do you see a lot of that, or what do you have any input? I don't know, from your practice, Dr. Khorana?
So you see a lot of patients that are what? I'm sorry, I missed that part.
Uninsured.
Uninsured, yeah. Access to care is definitely, is an issue in the younger population. And it might be something as simple as they just didn't sign, it's, you make decisions when you're 21 or 22 that, that in retrospect are really dumb, but, they just didn't sign up. They missed the deadline for signing up, even though they have jobs, or they have jobs, but they're like, consulting jobs or something, or contracting jobs, and they don't have health insurance that goes with that. So we definitely see a part of that, and it definitely does lead to delay in care, no question about it.
Yeah. A couple of additional questions in the chat box from Stacy George. How did you get buy-in from administration to send out that many kits and that may or may not be returned? This is for our case presenter group. I get pushback from the money loss kits not returned. So Sable, does your team want to take that?
I'm sorry, we asked that question again. We were discussing why the younger people have it on the right side, not the left side. We asked the question
Sure.
again.
Sure. So how did you get buy-in from administration to send out that many kits that may or may not be returned? Because like you were saying, we send them out to all of our patients that are eligible. We don't want them to leave. If they're eligible, we don't want them to leave without the kit. This provider, Stacy George, is saying, I get pushback on the money loss from the kits not returned.
So we kind of just weighed out our benefits. It costs about $3.50 for us to buy each kit. We do run them in-house, so that saves some money. The only money that we're really losing is on self-pay patients, and the money that we gain with the insured kind of just eats their cost up.
Yeah, that's an excellent point. So it's pretty ineffective or inexpensive form of screening. This kit being less than $5, and so and then you actually make money from patients that have insurance off those kits, and so that's kind of how they convince their administration to send those kits out. Dr. Hotz has a question as well.
Yes, Dr. Khorana. One of the challenges that I see, I'm the medical director of the west side of this program, is how infrequently we identify above average risk. I rarely ever see family history of polyps included. Often personal history of polyps is not. And as far as getting family history for Lynch and other inherited things, we rarely see it. I have seen people quote that we should not, we should be seeing about 15 to 20% of the people who are not average risk who should go to colonoscopy because of other factors, their own personal polyps or family history. But what I'm seeing is usually it's less than 5%. So could you give us some idea, as somebody who's practiced and see these cancers, what do you think should be the number of people that are identified as above average risk who require colonoscopy only?
A great question. I think I know where that 5% number is coming from, because that's about the rate of inherited syndromes. And so if you add up like Lynch syndrome and FAP and a couple of the other ones, it's in the range of around 5%. Some people would argue it's maybe as high as 7 or 8% of all colon cancer. But that's not the universe of people who need to be screened, because the universe of people who need to be screened aren't just the ones with a known inherited syndrome, but it's also the ones that just have a family history, but they don't actually have a recognized syndrome, because they are at higher risk for getting colorectal cancer, or people with personal history of polyp, family history of polyp, and so on. I mean, the beautiful thing about colonoscopy is that it's not, unlike mammogram where you're just identifying the disease, a colonoscopy is preventative, right? I mean, you go in, you take the polyp out, it never becomes cancer. And so I think we need to get that education out to as many people as possible. I think one of the changes that's resulted because of this drop in age to age 45 is that maybe we'll capture some of those more of the high risk people, because we've sort of made this general 45 and older, and we might capture people. I just saw somebody this week who was 52 and had her cancer diagnosed because she had a screening colonoscopy, and she knew she should have gotten it at age 50, and her physician said you have to have it at age 50, and she refused, and she came back at age 51 and refused. And at age 52, the third time the physician brings that up, she's like, fine, I'll do the Cologuard. And then that was positive and led to the colonoscopy, which led to a stage 3 cancer. Or if she had gone in at age 50, maybe it was just a polyp that could have been taken out and she wouldn't have had cancer. And so when you see these people that are sort of, okay, they're buying into it, but it takes them a few years to buy into it. If you start at age 45, maybe we'll capture more of those people as well. But it really is just, what you're doing here, which is education, 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 both providers and patients.
Thank you.
All right, thank you. That was good input. So I think Dr. Islam, your hand was raised.
Yeah, I had a question. I wanted to thank you, Dr. Khorana, for its wonderful and very informative and facts-driven presentations.
Thank you.
I had a couple of comments and also a question. You mentioned that the predilection for the colon cancer among early age and later onset left and right colon different differentiation. Is there any biological factors that are responsible for this differential distribution on the colon? If you make a comment on that, that'd be very helpful.
Yeah, it's probably, it's definitely being investigated, I would say. I think there's sort of a couple answers to that. One is that, if you go back to sort of embryology and where the left gut comes from versus where the right gut comes from, they don't come from the same source. And so genetically speaking, they're slightly different. And if you get cancer, you see different genetics in the left side of the colon and different genetics in the right side of the colon. So I think it is biologically driven. The other aspect, of course, is the microbiomics that I referred to before, which is that the microbial profile also differs between the left versus right side of the colon. So the short answer is yes, I think it's biologically driven, but we don't have a clear handle on that. And why, if it's biologically driven, what is in the etiology of young onset that's different than older onset that's driving this left-sided, presentation? Also, we don't fully understand that. So lots of work to be done there.
Wonderful. Yeah, if you have time, I have another question. It's related to you mentioned that young onset, even stage 4, offers surgical management. Is there any data that shows it has better outcome?
What has a better outcome? I'm sorry.
You mentioned that when you show the picture between difference right and young onset and old onset, you show that the young onset patients with a stage 4 cancer, there is a surgical treatment option. Whether that has any, outcome has better compared to those who have not done. Is there any result or any comment of that?
Yeah, I think it's at least partly driven by delay in diagnosis. So by the time, because it's not recognized, so by the time it's diagnosed, it leads to a more advanced stage. I think that's part of it. And then if you have a more advanced stage that, for instance, you have liver metastases, then obviously your surgical decision-making is going to be different. The second aspect is that biologically, the cancers in younger onset patients they're more likely to be poorly differentiated. And they're more likely to be hypomethylated, which can make them more aggressive. So it may not just be a delay in diagnosis issue. It may just be that these cancers are, for lack of a better word, they're more aggressive clinical, they behave more aggressively, and therefore they're spreading faster, and therefore surgery, may not be as obvious an answer as it might be in an older population. So that needs to be sorted out, but this is part of the difference between this young onset and usual onset colorectal cancer, for sure.
All right, thank you.
Oh yeah, thank you. Very interesting. So we have a question from Mary Beth Curtis, who's from Arkansas. Should anemia of a unknown source be considered as a possible sign and symptom of colorectal cancer? And then a FIT kit, could you consider a FIT kit for those patients?
Yeah, definitely anemia with, no other obvious explanation, and again, don't assume the explanation. So, it has to be an actual explanation. And yeah, FIT would be a simple test to consider. If you're using FIT for screening, obviously that has to be done every year and not infrequently as you do scoping. But I would say yes, the answer is definitely yes.
Thank you. And then Dr. Hotz has an additional question. You didn't discuss viral infection like HPV and HIV. We care for a number of these patients. Did that contribute to increased risk?
Yeah, HPV is more likely to contribute to anal cancer. There is some aspect of anorectal cancer that's increased as well. So you can see squamous cell carcinoma of the rectum, for instance, that is HPV driven. But the risk of that is still fairly low. So it's maybe like 0.3% or 0.2%, something like that. It's in the very low numbers. So it's not, I don't think it's contributing to the rise in incidence, which actually, you know, if it were, there would be an easy fix, which is that everybody get their HPV vaccines. But, you know, I think that's a solution for cervical and anal cancer, but not so much for rectal cancer. HIV, there is a slightly increased risk of all different types of malignancies, including colorectal cancer. But again, most people these days have HIV very well controlled. Viral loads are very well controlled. And so it's not a significant contributor to this rise in incidence.
Good to know. Thank you, Dr. Khorana. So we're coming close to the conclusion of our presentations. If there's any last minute questions, anybody wants to quickly raise their hand, we can maybe do one more question. If not, we're going to go to the next section of our session, which is the CME part. And so thank you, Dr. Khorana. Thank you, our MAs, Amber Smith and Raven Thomas, as well as our clinical liaison, Sable Fleming. We will be, I'll be passing on the presentation to Dr. Islam, who's going to talk to you more about CMEs.
Oh, thank you, Dr. Kush, and thank you for leading the session and the discussion section for today's presentation. I also would like to extend my sincere thank you to Dr. Khorana and the case presenters for their contribution today and those who participated to our session. We bring a free of cost to you all participants to CME and CNE certification for the participation for our sessions. If you want to claim, please follow the link posted on the chat session or use the QR code you can see in the slide in front of you. Also, we wanted to invite you, encourage you to share or volunteer if you have any case presentation for our future sessions. Please communicate with us at AU_CRC screening@augusta.edu. We have a session every month. Our next session would be first Wednesday in June, which is 7th of June, 2023. And I really appreciate your participation and contribution to our sessions. Again, thank you very much. And I really, I'm trying to encourage everyone, those who would like to share again with your case presentation. We need your contributions. Thank you. Have a wonderful day and a good week ahead of you. Thank you, everyone.